So yeah, I'm here to talk about the physician role in intervention and medical management of the chronic pain patient. Basically introduce the interdisciplinary pain program that we're introducing to our patients here in Southern Illinois. So no financial disclosures, objectives, review patient evaluation methods for chronic pain, outline non-pharmacologic and non-opiate pharmacologic treatment options in chronic pain conditions, explain various roles involved in the IDT approach, explain how the interdisciplinary pain management approach can enhance management of chronic pain. So, the International Association of Study of Pain has defined pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. But we know there's more than that. So there's, chronic pain, which is defined as ongoing or recurrent pain that lasts beyond the usual course of the acute illness or injury or more than 3 to 6 months, and which adversely affects the individual's well-being. But there's some problems with this definition of chronic pain. That's why there's now like this new classification where you have chronic primary pain and chronic secondary pain. Because again, there's some chronic pain conditions where there's underlying disease condition. So we'll discuss that more in a little bit. So chronic primary pain, you would define this as pain in one or more anatomical regions that persists or recurs for longer than 3 months, is associated with significant emotional distress, anxiety, anger, frustration, or depressed mood, and or significant functional disability, meaning interference in activities of daily life and participation in social roles, and the symptoms are not better accounted for by another. So we have this classification where under chronic primary pain, there's no actual disease condition that would explain it. While you have your other chronic secondary pain where you have an actual disease condition that will explain for it. So for example, chronic post-surgical pain, certain burn patients will have these chronic pain for more than the 3 to 6 month period. Chronic secondary musculoskeletal pain, your rheumatoid arthritis patient, one example. Chronic secondary visceral pain, inflammatory bowel disease conditions, chronic neuropathic pain, see this, or like your stroke patients when they have their central neuropathic pain. So, and then chronic secondary headache or facial pain, your migraine patients. So, how do we explain this? What's the chronic pain pathophysiology? So there are newer studies that show that there's actually changes in the brain with chronic pain. So there's the anterior cingulate cortex, which registers unpleasant physical and emotional feelings. And they found out there's increased activity in this region as pain sensitivity increases. In the amygdala, this is the part of the brain that assigns emotional value to sensory information and anticipates pain and perceived threats. So the activation of this contributes to pain-related fear, memory, and pain modulation. Also, like in the hippocampus, so this is a part of the brain where there's formation of memories, spatial processing, emotional processing. They found that there's decreased hippocampal volume found in chronic low back pain and CRPS. So with the dorsolateral prefrontal cortex, there's a lot of studies on this. So this is involved in executive functions. It's the keynote of several brain networks implicated in cognitive, affective, and sensory processing. So they also found that there's decreased gray matter in the dorsolateral prefrontal cortex resulted in these maladaptive coping strategies. So as you can see there, they found it is actually smaller. So they did this longitudinal brain imaging study in subacute back pain patients. They were followed for over 1 year, and they found that when pain persisted, the gray matter density decreased. If there's greater functional connectivity in the prefrontal cortex, this predicted pain persistence. So, but they were also able to demonstrate that you can reverse this. So there have been some studies that there's reversal of the prefrontal dorsolateral prefrontal cortex abnormalities after successful interventions for chronic pain, and this included the multimodal interdisciplinary approach. So different modalities that are used under this type of treatment, like cognitive behavioral therapy. So as you can see, in an interdisciplinary multimodal pain therapy, you have the physician, you have nursing, you have behavioral health, and you have occupational therapy and physical therapy. So they work together in these structured programs, and they have shown to be effective in alleviating chronic pain of different entities, including those where interventional therapy options were lacking or have been unsuccessful. So they compared it to like unimodal interventions, and they've proven that this is definitely more effective for chronic pain. So as the physician, as the gatekeeper, I will discuss some evaluations, but I will not discuss the whole evaluation that we do, but some key measures, key evaluation measures that we do to be able to rule out is this chronic primary pain, chronic secondary pain. So like knowing the red flags, right? So again, these are diagnoses that we do not want to miss in back pain. So there's in certain types of pain like back pain. So I'm going to use back pain as an example since it's the more common chronic pain, cause of chronic pain. So there's cancer, there's infection, injuries to spine, cauda equina, herniated nucleus pulposus, stenosis, unstable vertebral fractures. Sometimes can be visceral pain like abdominal aortic aneurysm. So for cancer, usually we try to see, do they have a history of cancer? Is there any unexplained weight loss? Any age over, we also look at their age. And then if, definitely greater risk factor with certain age groups. And then failure to improve with therapy. That's why, we communicate with you guys. So if there's, this persistence of pain despite 6 weeks of therapy, maybe we need to do look into this. Is this actually this is not just chronic primary pain, but maybe this is something more than that. Okay, so night pain or pain at rest would be another something to look for. So if you're having that in your history, then we do our physical exam, do imaging to be able to rule out this condition. So another diagnosis you don't want to miss, infection, especially like a spinal infection. So if you have persistent fever, history of IV drug abuse, severe pain, lower spine surgery within the last year, or any recent bacterial infections such as UTI, cellulitis, pneumonia, or an ulcer, especially if it's near the spine region. Patients who have immunocompromised states like systemic corticosteroids, organ transplant, diabetes, HIV. Then again, cord injuries, things you want to rule out, like when you look at their history, this patient having any urinary incontinence or retention, saddle anesthesia, they have fecal incontinence, decreased anal sphincter tone, then look at their neurologic deficits, so lower extremity weakness, numbness, and correlated if they have what you call your upper motor neuron signs, hyperreflexia, clonus, Babinski, or if they're having any spasticity. And again, in back pain, if patients have unstable vertebral fractures, so you also want to rule that out. So we see this with patients with prolonged use of corticosteroids, age greater than 70 years, history of osteoporosis, or patients who have mild trauma over age of 50 years, recent significant trauma at any age, like injection, fall from a substantial height. Then, like abdominal aortic aneurysm is also something that can cause back pain. So, when we examine them, of course, we try to see is this, something more visceral, like abdominal pulsating mass, if patient had history of vascular disease, or having pain at rest or nocturnal pain, or also greater risk factors, of course, in patients who are age greater than 60. So aside from the red flags, I know this has been discussed in earlier lectures, your yellow flags. So you also want to look at that because, yes, this will be very important in management, especially with referral to behavioral health. So there's more. They have, some studies have actually classified this yellow flags as actual risk factors. They have designated as red flags, orange flags, yellow flags, blue flags, and the black flags. So, red flags, of course, are sign or serious pathology. Orange would be your psychiatric symptoms. Patients who actually have an underlying psychiatric disease, you definitely have to know that as you are treating these patients. So your yellow flags, yes, that's when you actually look more into their beliefs, appraisals, and judgments, their emotional responses, their pain behaviors, and then the blue flags would be, their perceptions about relationship between work and health. And then your black flags would be your system or contextual obstacles, like anything like conflict with insurance staff or injury claim. So, those are things that we definitely want to identify in our patients. Okay. So again, focusing on yellow flags, examples of these would be unhelpful beliefs about pain, so expectations of poor treatment outcome, and then with emotional responses, they have significant distress, not meeting criteria for diagnosis of mental disorders, worry, fears, anxiety. And then in terms of their pain behavior, examples of these would be avoidance of activities due to expectations of pain and possible re-injury, over reliance on passive treatments. Okay. Right, so questionnaires that identify as yellow flags, I know this have been discussed. It's going to be a more individualized approach, and of course we'll be working together with behavioral health on this. So just some examples in terms of management. So again, we want to do an interdisciplinary approach. Now for the physician role, yes, we will also be in charge of like medication management, interventions. So just some common guidelines in terms of like management. So CDC guidelines say us that opioids are not the first line or routine therapy for chronic pain. So we'll definitely be doing a lot of opioid weaning for patients, encouraging multimodal therapies, other alternatives for them. So again, I say clinicians should consider opioid therapy only if expected benefits for both pain and function are anticipated to outweigh risks to the patient. And if they're used, then it should be combined with non-pharmacologic therapy as appropriate, and like doing this interdisciplinary approach. So again, like for CDC, some effective treatments for chronic pain, non-pharmacologic therapies, exercise therapy, cognitive behavioral therapy, some common ones, some common treatments, of course your acetaminophen, NSAIDs, anticonvulsants, antidepressants, interventional approaches, and then your multimodal therapies. Okay, so as we know, when we educate our patients, benefits of exercise therapy would be there's greater exposure helps to desensitize a sensitive nervous system. We would always educate them on that. That was discussed in the earlier lecture. They reduce pain, improve function in low back pain. They improve global well-being and physical function in fibromyalgia, as an example. And additional benefits, as we all know, they cause lower rates of all-cause mortality and heart disease, high blood pressure, diabetes, depression, and there's definitely decreased risk of vertebral fractures and increased level of cardiorespiratory and muscular fitness. So, World Health recommendations regarding exercise would be 150 minutes of moderate intensity aerobic physical activity or 75 minutes of vigorous intensity aerobic physical activity per week. So it should be performed in about at least 10 minutes duration. Muscle strengthening should involve major muscle groups twice a week. And then physical activity can include any of the following activities such as walking to store, riding your bike. So, just basically educating patients on exercise therapy. So another treatment for chronic pain would be your cognitive behavioral therapy. So this addresses psychosocial contributors to pain and improves function. So to train patients in behavioral techniques, we help patients modify situational factors and cognitive processes that exacerbate pain. And studies have actually shown that there are positive effects on disability and catastrophic thinking. So there were studies that again went back to looking at the prefrontal cortex, as we have discussed. So they have suggested that with cognitive behavioral therapy, there were changes in the brain's processing of pain. So there was another study where there's mixed chronic pain types, where there's actually decreased pain catastrophizing after 11 weeks of cognitive behavioral therapy. And as you can see, there was increased gray matter volume in the dorsolateral prefrontal cortex and even other parts of the brain that were responsible for processing of pain. So, as a physician, some treatments that we give these patients would be medications, but what are some things that we need to know about? Of course, we want to make sure that we're also looking at the patient as a whole, taking into account their medical conditions and then side effects. So some things to know about, like these pharmacologic treatments, so like Tylenol or acetaminophen. So it definitely inhibits prostaglandin synthesis by acting on the COX enzymes. So this reinforces descending inhibitory pain pathways. Now, multiple guidelines show it's actually first line for low back pain, the chronic primary pain. But some things we have to make sure of, patients have hepatic insufficiency, history of alcohol abuse, geriatric patients. It's advisable to reduce the dosage by 50 to 75%. It's hepatotoxic at 3 to 4 grams per day, and at lower dosages in patients with, again, chronic alcohol use or liver disease. So your NSAIDs act on the COX-1 and COX-2 enzymes, inhibiting prostaglandin synthesis. So because of this, there are certain side effects that we have to watch out for. So there's gastritis, GI bleeding, fluid retention. There's also renal and cardiovascular risks. So again, we have to take note into account with our patients, nephrology patients or renal patients. And again, this also interferes with platelet aggregation. So topical NSAIDs have less systemic risk than oral NSAIDs. So sometimes we prefer more of the topical treatments than their oral NSAIDs. Okay. Now, antidepressants. So they primarily achieve analgesia by increasing neurotransmitter concentrations of the noradrenaline and serotonin, which intensifies activity in the descending pain inhibitory pathway. So there's another study that looked at the functional MRI, and so they compared it from baseline at 1 week and then at 8 weeks. So duloxetine, an antidepressant, or Cymbalta is the brand name, is associated with significant reduction in brain responses to painful stimulation in chronic pain patients. And there's more effect with those with major depressive disorder patients. And because as you can see from here, initially there was abnormally enhanced activation, and they saw that there was less activation after the duloxetine treatment in 8 weeks. So some things to know about with these antidepressants. They're definitely effective and recommended in multiple guidelines for neuropathic pain. So chronic neuropathic pain, like your diabetic neuropathy. So, but they're contraindicated in severe cardiac disease, particularly in those with conduction disturbances, like your arrhythmias. So if they do have these conditions, but they really need it, so start at low dosages, then titrate up as needed and as tolerated. Things you also want to be careful about would be your anticholinergic effects, like which include sedation and urinary retention. So, sorry. So ideally it's used at bedtime. So other side effects of antidepressants, you have GI distress, weight gain, Yeah.
We have a question over here.
I'm sorry, Phyllis is much older than I am. I do have a question.
Yeah.
I've seen you do this. I've seen you
Yeah.
discuss antidepressants with patients that we have with chronic
Yeah.
pain. So my question for you is, when you're talking to a patient about the use of antidepressants for pain,
Yeah.
do you go into the fact that many of these patients say, I'm not depressed, I've
Yeah.
never had depression issues, now the doctor wants to put me on an antidepressant, and sometimes because they spend so much time with us, they'll
Yeah.
come to us with this sort of thing. Should we go ahead and
Sure,
say,
yeah. See, it's not an antidepressant. It's actually for your pain. Yeah, I think that would help when you were enforcing it, because we do tell them that it's, it's for your pain. It's not an antidepressant. So this is the generic name. You might see it's an antidepressant, but it's meant for your pain. Yeah.
thank you.
So, yeah, unfortunately, some of our patients need to have more education in it, and you guys are very instrumental in, continuing that education. So, all right. So, yeah, antidepressants in the geriatric population, again, we have to be mindful of the anticholinergic effects and the cardiovascular effects, and basically balancing the risks and benefits of the medication versus the other side effects. That's why in the geriatric population, we usually start pretty low, in low dosages. Anticonvulsants would be another pain medication that we use. So it inhibits neuronal excitation, they stabilize nerve membranes. So it's mostly used for, again, diabetic polyneuropathy, trigeminal neuralgia, and what they do is they actually bind to the subunit of the voltage-gated calcium channels, and then they modulate the pathologically enhanced neuronal excitation, causing pain. Okay. So common ones, pregabalin, gabapentin. So again, we have to start low and then increase gradually, because there can be some dose-dependent dizziness and sedation. So there are some anticonvulsants where we have to do some monitoring, like some lab work, CBC, liver function tests, because they can also affect the liver. But, again, balancing those risks and benefits. So other side effects we want to watch out for, weight gain, cognitive impairment, and then changes in mood for anticonvulsants. Topical treatments, again, you have examples with your lidocaine, Flector patch, Voltaren gel, Pensate, capsaicin, compound creams. So benefits would be pain relief. There's minimal systemic side effects, so it's really more localized. But then some risk would be skin irritation, and well, insurance usually doesn't cover it, and expensive, and sometimes that can be a challenge for patients.
Dr. Ona, I just know from previous experience, personal experience, I call it miracle cream, because it is a topical cream that's compounded. You could put multiple. Yeah, I mean, you could do like your NSAID plus a gabapentin plus a Flexeril.
Yes, yeah, I've seen that in this area. Yeah, and some of our patients are using it. So
and we do have there's a compounding pharmacy that is willing to do that, and I'm not sure about pricing, so maybe that's something we could see if they're getting much reimbursement for that. But man, I can imagine.
Yeah, I think some alternatives we can offer our patients.
Okay.
So again, some things we definitely consider as we consider our overall treatment for our patients, and when we use only the medications where benefits would outweigh the risks. We have a lot of geriatric patients, consider fall risks, and select dosing of potentially sedating medications, and then of course with patients who would be on NSAIDs, take into account if they have renal insufficiency, heart failure, peptic ulcer disease, or cardiovascular disease. So usually for those who are age 75, consider topical NSAIDs over oral NSAIDs. Again, considerations why we have to be more careful with our geriatric patients is because there are definitely some changes with normal aging. So there's less GI absorption and function, there's also less transdermal absorption, and then in terms of distribution, there's increased fat to lean body weight ratio, and this increases the volume and distribution for some fat soluble drugs. Okay, so they also have some issues with liver metabolism, renal excretion, and then in terms of, again, as mentioned, they have greater side effects, especially with anticholinergic side effects. There's increased confusion, there can be more constipation or incontinence, and certain movement disorders. So interventional approaches, just a few examples, and then we're using again back pain. There are definitely various approaches for interventions. I know Dr. Burchell will be discussing the interventional approaches, so I'll just be going over this quickly. So examples being your epidural injections, where you use anesthetic and steroid medications to, and inject it into the epidural space. You have your nerve root and medial branch blocks, your facet joint injections, discography. So basically, this involves the use of a dye that is injected into the disc and then examined using X-ray or CT scans. Your radio frequency procedures. So this is a minimally invasive procedure where you disable spinal nerves and prevent them from transmitting pain signals to the brain. There's also rhizotomy, spinal cord stimulation, intrathecal pumps, percutaneous discectomy, or nucleoplasty. So again, we definitely look at the patients first and then see what specific treatments would apply to them. So in the interdisciplinary pain management, so basically what is done is, you work as a group. You're working with behavioral health, you're working with nursing, physical therapy, occupational therapy. So this is a team approach where there's we use educational approaches to teach patients regarding effective, active self-management strategies. So, and then you're actually allowing all components of the patient's pain experience to be treated simultaneously in an integrated fashion with a goal of reducing pain and improving function. So instead of talking about pain, you were focusing more on function. Let them know like, hey, look, you're actually improving. See what you can do now. So yeah, that's what we're trying to encourage for a patient. So this treatment approach also extends to include, secondary pathologies such as fear of movement, pain catastrophizing, anxiety, and nervous system sensitization. So again, that's why it's very important to know those yellow flags and work closely with behavioral health. And as I've also shown earlier, the studies have shown that this is definitely more effective than the usual care and is moderately superior for pain outcomes. So as you can see here, we're definitely applying the psychosocial approach instead of the biomedical approach for our patients. Goals of the interdisciplinary pain program would be to increase physical activity, decrease pain intensity, improve pain medication regimen, improve psychosocial functioning, and then for patients to return to leisure, and then reduce utilization of healthcare services. So features of the interdisciplinary pain management program. So you actually customize the treatments to the individual patient needs, and then you specify measurable goals and endpoints of the treatment, and then you monitor the progress toward goal achievement, and then there's also some expectation of participation on the part of the patient, caregivers, and significant others. So like in Chicago, they also try to encourage the family members to come and do education with them. So, and then there's also feedback that's provided not only to the patient but also to the referral sources. So again, that's why we have the interdisciplinary conference. So the meetings where the whole group is just like in inpatient and rehabilitation, where you talk about the progress, and then so that avoids duplication of treatments, and then the whole team is actually on the same page in terms of educating the patient. So members of the team, as I mentioned, would be your physician, nursing, behavioral health, physical therapy, and occupational therapy. So on our end, what we do is, on evaluation, we identify the patient risk factors, make sure that, this is not just chronic primary pain, or if they're actually chronic secondary pain, what other additional treatments would be needed. Then, making sure we're ruling out red flags and identifying risk factors, yellow flags, so that they have the appropriate referrals for behavioral management. And then adjusting medications, monitoring side effects, early intervention, education, and then we basically facilitate the interdisciplinary team meetings. For psychology and behavioral health, I know Sherry will be able to give you more insight on this. So basically, with the guidelines, it's assessment of biopsychosocial factors, education and acceptance regarding pain, psychotherapy, where you do cognitive restructuring, CBT, coping skills training, where you do emotion regulation, stress management, and again, family education, relapse prevention. I'm sure Sherry can add more to this. Basically, this is what the guidelines from.
How would you be adding family education? Are you gonna have a set day where the family can come in? Because I feel a lot of it is patients say one thing, so the family thinks another.
Yeah,
So that they're
so
all on the same.
we would encourage them to attend the follow-ups so that we can do that education piece with them. So and if sometimes you also have family members joining your therapies, so I think that would be definitely helpful. And I think in this program we can definitely arrange a specific appointment for that.
I think too, when you mentioned the team meeting, what we're gonna hope to get to in the future is no matter where they go, if they're part of this and there's someone part of the pain program that's seeing you, you'll, when we schedule the team meetings, that if you're treating that patient, you would be involved in that team meeting as well to talk about your patient's progress. So I know right now we've kind of centralized this until we get it really good and going. Starting with Katie and the people that have had some of the pain classes will be taking that on. And then we are going to look for more specific training of other therapists so we can really roll this out. I mean, this is a huge need in Southern Illinois, especially, and no one else is doing it. No one else, even on the basics level, and that's really Dr. Ona and I started having a conversation about what we could do. I can tell you from my perspective, this is one of my loves. I mean, I've done pain management for 10 years, and my doctoral work was all around chronic pain management. So I think it's so needed, and I'm excited that Katie and Dr. Ona and Sherry, of course, I think that the behavioral health piece is something we just can't be thankful enough, because as OTs we have some of that, but man, I'm glad to have the support of the licensed clinical social worker to do this with us.
Yeah, that's great. All right, so continuing on again, some other roles of psychology. They basically provide a full psychosocial evaluation, and then assess patient psychological strengths and weaknesses, and then these are all discussed in the team meeting. So and then use of CBT as an approach to psychosocial issues, and then basically communicate this in the interdisciplinary meetings. Okay. So with physical therapy, roles of physical therapy and interdisciplinary pain program would be foundational muscle activation and retraining, dynamic stability and functional exercise, educating on the physiological basis of pain, teaching of appropriate body mechanics and pacing, and again, communicating to the team findings from the therapy sessions about the patient's progress and monitoring treatment outcomes. Again, focus on functional exercise. And with occupational therapy, as what Katie has done, pain neuroscience education, pacing training, postural re-education, and body mechanics training, graded activity exposure, sensory processing and desensitization program, graded motor imagery sequences, and again, we also contribute to the interdisciplinary meetings, and so that we can discuss and monitor the treatment outcome for this patient. So, so advantages of the interdisciplinary program is that it's, again, it avoids duplication of investigations. It facilitates early and accurate diagnosis. It aids rapid initiation of treatment following diagnosis. Ensures availability of a wide array of treatment options. then, as you can see, it's a more individualized program. So care is delivered in a program and coordinated manner, and it provides continuity of interaction and care for the patient. Things also in studies where we saw the advantages of the program is that treatment failure can be recognized early on. There's definitely potential for improvement in the patient's quality of life, patient optimism and mood state. There's faster return to work, and patients have greater confidence in their treatment plan, knowing that it has been developed by a collaboration between different specialties. So, like with the pain neuroscience education, they actually tried to track patients who had back surgeries. So again, some patients after their back surgeries, they keep saying, well, the pain's still there, and when they only go to, for example, just a physician, and then who is not involved in this type of chronic pain program. So sometimes there are some unnecessary lab work, unnecessary imaging that are ordered, and after that, they get referrals that are also unnecessary, and this cost. You saw that it actually cost more versus a patient who was right after back pain surgery was involved in this type of program, and the cost savings was $2,678 for the patient who underwent this program versus a patient that didn't undergo this program had to spend more. So yeah, they have definitely shown that this is definitely effective for chronic pain patients and saves the system a lot more money. So yeah, in summary, we have discussed about chronic pain definitions to be able to see if it is really chronic primary pain, chronic secondary pain, and then we have also discussed about changes in the brain with chronic pain and what to do about it. So and application of the interdisciplinary approach for chronic pain patients. Okay. Any question? Yes.
Yeah, I wonder if, in my team in the Murfreesboro Clinic, we really an active proponent of physical activity as major contribution to eliminating pain, chronic pain. But I wonder if majority of doctors here prescribe aerobic, initiating exercise program for each patient.
Yeah, and I think that will.
You could write in your prescription maybe little physical activity.
Oh, like you're suggesting to us if you put in an actual prescription physical activity, yes, for us in our clinic, we say like a home exercise program. So yeah, we can, but again, I think this will be education for the PCPs, making sure that. So I think this will be an ongoing education for mostly the PCPs, making sure that they also prescribe physical activity to address pain.
And I think too, when these patients come in the program, they will typically see we're trying to have kind of like our specialty programs where they're evaluated by you'll know they're a chronic pain patient. It won't just look like a regular PT or OT eval. It will be designated to be a chronic pain so that you can identify that right on and know when you walk in. I mean, those of you who do women's health, when you walk in, you go to women's health. So, we just don't want, if this isn't a skill set that you have, then, we want to take that into account. But I think that, it needs to be with the education and all the things that we're doing, but these will be identified so you would know that, we're not going to, go back and start doing all the, same beginning exercises and things that we would do with that same acute diagnosis, so acute pain diagnosis.
So this is where Dave is going to come into play, because he's going to help roll this out to the PCPs to get it out to them. So within EPIC, we've already developed an ambulatory interdisciplinary pain program referral. So what that does is that alerts Dr. Ona's staff that it is a chronic pain patient that they're referring to her. So that's for the PCPs to put in for that referral. From there, we've built into EPIC the therapeutic pain specialist, OT, which is the referral to Katie, along with, ta-da, behavioral health, which we know that we cannot help these patients unless we help their behavior. And that's where behavioral health will come into play. And that is also built into EPIC, so those things can happen simultaneously. Dr. Anna can put those in. So the PCP can refer to Dr. Anna, and she can take care of all the medication stuff for us. And then we're working side by side with behavioral health with Katie, and then from Katie, she'll be able to bring in PT for the musculoskeletal side, and she will refer that back in. So that's how that circle works. And then we will begin to have team meetings just as soon as EPIC figures out how we're going to put that together. So that way all of us who's treating those people can actually bring those to the table to discuss with Dr. Anna. Again, getting that early, if something's not working, we don't want to just keep doing it. We want to try something different and make a move early rather than go 8 weeks doing the same thing and the person is in the same place they were.
So say we get the referral from PCP or whoever, chronic pain didn't go to Dr. Honor first, we immediately are like, hey, this is someone that could benefit from the program. Contact PCP to try to put a referral into Dr. Honor?
Absolutely.
Or do we?
Yeah, I would just, if they're, I would inbox their PCP and say, hey, after evaluation, I think this is appropriate for the ambulatory chronic pain program, and that's what I would call it. So then they can,
Yeah, we
if you
need
put
some
an order.
wording. So
Yeah.
ambulatory
So I'll get those-
chronic pain program.
Yeah, ambulatory interdisciplinary
Disciplinary,
pain
right.
program, because if
Yeah.
you say it the other way, it's going to go to a different group.
Can we get an email about that?
I'm
Yeah.
going to send an email about that, okay? But right now, because we want it to be a solid, from Dr. Anna to take a look, she's gonna help us rule out those red flags. So we've got that person looking at that. She's also going to help us with that pain medication that they're taking or hopefully weaning off of. And so she's gonna really assist us with that. So this is a really neat approach that we've not brought in the clinical social worker. A lot of times we work very closely with the physician on the therapy side, but we haven't really addressed the behavioral side to the extent that it needs to be.
Okay, so one more thing, how do we feel about, so say I've done a PT eval, charged insurance PT eval, and then they're gonna kind of go back, like, are we worried about, then I guess Katie's OT,
Correct.
but say it's Marcia that does an OT eval, you know what I mean, like, are we worried about,
Katie would charge it.
would she
needed
keep
it
the
in,
chart
see
open?
Katie.
Okay.
Yeah, right, and
Just
Katie
kinda
would,
do it like a
you would keep it and
reassessment?
she would do,
Yep.
an update.
Okay, so
We
maybe
would
we could just
recharge
like
it
kinda
back.
have like a little,
I'll have a flow sheet.
yeah, flow sheet of how you want it.
I'll do a workflow for you, okay?
Yeah.
And then use the wording that
How would we write our plan of care then? Are we just
To-
referring out?
For
and
I would
no
say
discharge? So
yeah.
no goals, but we would discharge?
You wouldn't
For
discharge.
PT,
you wouldn't
right?
necessarily have to.
Well, here's the thing, remember, the program's gonna go simultaneously, so if Katie evaluates, you see it and you say, hey, if PT sees it first and says, I think they need the program, it's gonna go to Dr. Anna, Dr. Anna's gonna see him, Dr. Anna then they'll see Katie, and then Katie will, re-engage you, so on hold until after,
Okay.
Dr. Anna, and then it
So
would
don't
come back.
discharge her.
And then you'll put a message in basket to yourself in 2 weeks for future follow-up so that you know that person's on hold.
And the same thing OT, you would just,
Same way.
your plan would be, we'll refer to, plan is to refer to the interdisciplinary pain program for,
Correct.
for further, and we'll update after evaluation by physician.
So then on a PT side though, since I work with Ruth Ann and are you kind of gonna gear these patients
Yeah.
more towards the therapists that have been through the extra training, is that, and then
Yes.
that kind of the thought, so then I would really transfer them, if Katie thought that she needed PT for the musculoskeletal, whatever, then they would be
Correct.
transferred over to
Yes.
Ruth
Yeah.
Ann.
Or Ruth Ann, Janelle, so we have them in some different clinics as well. Okay?
And now, the other thing I might say is, we're gonna roll this out very, very slowly. We're
Right.
gonna pilot
We
it
wanna
with
get it
like
right.
we can't, if we opened this up and just said, hey, we have a new chronic pain program, we would not, I bet we would have so many referrals, there's no way we could even remotely keep up. So it's gonna be very small, pick one primary care. I've already had a request, as I rolled this out to, senior leadership this past week, I've already had a request that they be that Brandon Spine be our first, that they get first dibs to start, because of the nature of their patients. So we, again, we want this to be very successful. I think this will grow. I feel like this will become a whole department at some point.
But we want to do it well. We don't
Yeah.
want to do it just half-baked. So that's why we want to roll it out so it will be successful, and that we supply you guys with the training and the comfort zone that you'll be able to take this not only on the outpatient side, but we can begin this early on the inpatient side, because many times people are in the hospital, they have chronic pain, not just
I have a
hospital.
question for Dr. Otta.
Go ahead.
Dr. Otta, so in that gray area, they have chronic pain, chronic back pain prior to their surgery. Now they have surgery. We get them in acute rehab 5 days post-surgery. And now the pain is the opioids that they were on is being decreased, and now there's that conflict of, I used to take them, now you're taking it away from me, and usually so you probably will get that referral to this chronic pain.
Right, I think.
But they do have a legitimate acute pain,
Yeah.
they just got
That's
cut.
our real,
So-
the evaluation, is this like chronic primary pain, is this chronic secondary pain, and, looking at the guidelines, like for example, definitely they have an acute pain that's being treated right now. So, yeah, we definitely take that into account, and then we look at, when would we start the weaning process for this patient.
And I can see, I could just see and I can see in that scenario, like Dr. Virgil, who's there every day, calling Dr. Anna, not just Katie, but also calling Dr. Anna in to have that same conversation between, like calling the team in. So as you can see, we're going to be needing at least one, if not two more certified therapeutic pain specialists, because
Right.
Katie is only one person and can't cover.
And it is a 6-month commitment, it is a certification, so you do have to have, like she talked about, there is a capstone project with it, so it is a commitment for those that would like to take that on. Questions
You
for
can
Dr.
talk to
Anna?
Laura if you're in that, if you're
Yeah,
interested.
just let me know
You're
if you
so
are
enamored
really
today.
interested, and we'll talk. Questions for Dr. Anna, medication, opioid reduction, any of those types of questions?
So we're talking about moving more as part of pain management, right? So everyone's recommending movement or exercise, aerobic activity. Is there any possibility or study or anything that's saying get people a free gym membership, that would actually reduce the overall cost of their pain management if they were to actually take this on?
There are studies about exercise, so, yeah, but in terms of actual gym membership, this was a big
I mean, how much cheaper would that be than physical therapy for those people who can get up on their own, move on their own, just need to?
The problem is the motivation. So most of the time, we've all bought, that's how gyms stay in business, is because come January, everybody buys a gym membership for a year. The busiest times for gyms is from January to March, and then those people never come back, but that's how the gyms live. So these people need some guided information while they're exercising, that hurt is okay, but look where your function is.
And you hope that that's the end of your treatment, that
Is
when
that
you
they go to the gym.
discharge, is that they now sign up. Because they're not gonna be okay doing it in the beginning, because these are chronic pain patients, and just saying, you need to go out to the gym.
And afterwards, absolutely.
After their
Yeah.
education,
Yes.
is that something that could be part of the program?
It could be, that's a good point. We
Then
can,
they have the motivation without the
to do it.
financial obligation.
So you're saying SIH provide the free gym membership, is that what you're suggesting?
Most of their insurance a lot of your insurance companies will. Unbelievably, a lot of your health insurance companies have a list of gym memberships, and you can turn those in. I'm trying to think of,
Maybe they need to be educated about that option.
exactly,
That's-
yeah,
yeah.
and to help supply that information, definitely. Other questions? Anything that you've ever wanted to know about opioids?
Yeah, but definitely all your inputs will be helpful, because again, there are some guidelines regarding this program, but, this is a program that we want to be more individualized for our Southern Illinois patients.
Yeah.
So, any inputs from you would be very helpful.
and I know that SIH had a history with the pain program previously, and we tried to emulate what Shirley Ryan did. And honestly, their program is evolving.
Yes.
They're changing it. The days of having people drive to Chicago and stay there for 3 to 4 weeks, and receive treatment 5 days a week, and stay in a hotel and go and get this. It's still the interdisciplinary. But you can't do that process anymore. Insurances aren't paying for that intensity. We're not seeing, so they're adapting theirs, and that's really what we were trying to do here years ago. From what I understand,
Yes.
it was very similar approach. So I think we're trying to take an approach that's really it's gonna be, unique to us. And again, the communication piece, if you're not sure, Dr. Anna is very open, you can in-basket her.
basket.
She is, and she's gonna respond to you, and I think that's the easiest way. Don't feel like, she'll get to it when she has time, that's when she's checking it all the time at her in-basket, so I think that's the, and she's learned how to sort, so she knows what's important to her. So I think that's, really critical that we use that communication tool as you're seeing those people and you think that they could benefit from this. Again, that's part of the way I fear that this is gonna start snowballing, is because you all are gonna see these, and I don't wanna discourage that, but I think that's part of our, the marketing in itself. We don't have to spend a lot, because as you see people who are referred because they are chronic pain and their primary has no idea what to do with them, so we're just gonna send them to therapy. Once they get that and then you recognize it, they're gonna go, what is this program? And then they're gonna have it for future reference. So again, I feel like that's gonna be our marketing strategy a lot for this. Pilot it and then let you all kind of drive some of that as you see patients who need this.
So you guys touched on what that looks like on an outpatient basis. Can you discuss that a little bit on what that really looks like, current state, future state for inpatient, or acute rehab, or swing bed?
Yeah. I think right now, what we've done is on inpatient rehab, Dr. Burchell is aware that he can call and make that referral. It's clunky. It's going to be clunky for a little bit until we get some additional training. We have Daryl, I know, has been working on Katie's schedule to make Katie, to make sure she can get in there. Laura is working on an inpatient interdisciplinary pain program team as well. So I think that is somewhat of a bonus for us to be able to have input into that.
And they are very interested in what we have to offer as this team to add on to that inpatient pain management.
And
So they're looking for solutions and for help. The nursing side is. And that's something that we can bring.
I think this is evolving. I think it's going to be changing. We're trying to make it. I know Laura had been looking at making some inpatient orders similar to those outpatient orders where you could put in that ambulatory interdisciplinary pain program orders so that we can have that on inpatient. We're also looking at, working with several people to try to get back to the point where we can look at some alternatives. Alternative therapies, both on inpatient and out, like, how we all had the diffusers and we had aromatherapy and then they took them all away, and how critical some of those tools could be for us to have as a pain management tool on the inpatient side as well as the outpatient. So kind of getting a committee together to do some of that as well.
And Sherry's going to talk a lot right now, but we all know that the person that's in the driver's seat is the patient. So unless we get the patient driving the bus down the road where we want it and not going the back roads, winding around, because we also know that the patients do a lot of doctor seeking in order to get prescriptions and medications and hospital seeking and that. And so that's what we want them to be driving the bus down the right road and making the right decisions.
And something we haven't mentioned, which I might ask only because I've suddenly become the expert in this, is the marijuana, both medical and recreational use. It is now, since with the changes in the law, the medical no longer requires a physician prescription. You also have the ability, if you have an opioid, there is if you have an opioid prescription, there's a pilot program that you can go to one of our area dispensaries and you can turn in your opioid and you can get a medical marijuana in replacement of your opioid. So you no longer even have to see the doctor, you no longer have to have that. If you have the prescription, you can take it and get a replacement. But you no longer have to have the prescription from the physician to get the medical marijuana card. You have to have certification form signed saying that you have a certain diagnosis. So all they're asking is the physician sign there, here's the diagnosis they have, yes, 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 and sign your name. And so the medical marijuana world did not take off in Illinois like they thought. It would, because, in the use and the cards, because we didn't have, I mean, people didn't have access to get a physician to sign up, especially in Southern Illinois. There was like one physician that is, I don't even know where he's at or whatever, but prior to this changing, people had a very difficult time getting the prescription. This is going to be, and obviously in January, they no longer need the prescription, they can walk in and buy it. So I think we're also gonna see a change in this, and we have to, we have to embrace it, it's legal. It's like saying, yeah, my back hurt, and so I had a couple of drinks last night, boy, that helped my back, you know what, I mean, but we see the benefits of it, and I think, to acknowledge that's what they're using and that's improving, I don't really know that we have to address it any other way, do we, Dr. Hunt?
SIH, doesn't encourage.
We don't take a policy, right, we don't tell them, maybe if you get some marijuana, you.
Don't go out there and tell
Yeah,
everybody
let's not
that
be
you have
telling
toast.
that.
That's
Yeah, maybe
not,
just take it into account in your history, knowing that, like us, we're treating.
but hopefully they'll be more up.
Yeah, we won't encourage
No.
that.
No, but you do wanna know, you wanna know if they're
Yes,
using, you wanna know if that's
Yes,
part of the
yeah.
regimen.
We have questions?
So, like with our, because I work with Dr. Ona, so,